Thank you very much indeed, Jess, and thank you everybody for beaming in today. Obviously, there's a lot of different challenges in relation to different webcasts, etc. So really delighted that you joined us today, and hopefully we'll stimulate you and make you think a little bit about why data saves lives. Next slide. So what I thought I'd do is really talk a little bit about how we've used data, and particularly real-time data, in influencing cancer policy during COVID-19. Next. For me, this whole story starts with a personal aspect. My uncle died on the 29th of March of this year of a COVID-related illness. And Edward Dodoliak, who's a colleague of mine from Croatia, from the University of Split, reached out to me to commiserate with me on my loss. But he also said the following. He said that in Croatia, people were starting to fear a COVID-19 diagnosis more than a cancer diagnosis. And that really worried me. Because anecdotally in the UK, we'd heard similar stories, but there was really no data to either back up that assertion or refute it. So in DataCan, which is the UK's health data research hub for cancer, we decided to start a collaboration, a data-driven collaboration with University College London to really try and find data that would either back up that assertion in relation to people fearing a COVID-19 diagnosis more than cancer. Next slide. And the work that we did was in two parts. Next. One was to look at real-time data, and we feel this is really important, looking at real-time data from hospital trusts across the United Kingdom. And we decided to look at two measures that are routinely captured by hospitals. So something that we could easily look at and then infer from. The first was 2-week waiting time, or sometimes called red flag referrals. This is the early warning system that we use in the UK for suspicion of cancer. So here what we're really looking at is the diagnostic pathway. And then we also looked at chemotherapy attendances and changes in those, which is a good proxy of the health of the cancer treatment pathway. And so looking at these two and looking at weekly data from hospital trusts across the United Kingdom, what we found was, next slide, was that we really saw precipitous drop in relation to both 2-week wait referrals and chemotherapy. If you just concentrate on the green sort of yellow shading in these two graphs here, you can see there a very significant drop, and no matter which hospital trust you look at across the United Kingdom, particularly so in relation to 2-week wait, so that referral pathway, but also in relation to chemotherapy. Next slide, please. And so if we look at this and put some numbers on it, and we now are starting to get very used to numbers because we see them every day, no matter where we are in the world. So we saw a median of a 70% drop in relation to 2-week waiting time referrals and 41% in relation to chemotherapy. But what does that really mean? So what does that mean to the individual? Next slide, please. What that means to me, accessing that health service, is that 7 out of 10 people who had a suspicion of cancer were not getting referred to a cancer specialist service. And it also means that 4 out of 10 cancer patients were not getting access to their chemotherapy. This data really worried us. So straight away, sorry, just go back to the previous slide. So straight away, we reached out to the government, to the academia, to the NHS to show this data. So we actually provided this data before we submitted it for publication. And what we really reached out was to the 4 chief medical officers and the National Director for Cancer, because we thought it was really important to see this data and the potential impact it was going to have in relation to cancer services, but most importantly, cancer patients in the UK. Next slide. So why did we use real-time data? Well, hopefully this slide will show you. So on the left-hand graph, what I'm showing you is looking at on the 9th of June, what we're doing is we're looking to see what does the national data for 2-week wait look like in England. And when you look at that graph, it doesn't really show you much differences. It's more or less the same. It's more or less a straight line with a few minor variations. Why is that? The reason for that is, although we looked at this data on the 9th of June, if you actually look at the graph itself, the data is from March. So the data is over 3 months old. If we contrast that with the next slide, where we actually look at the real-time data we had collected, you can see it's much more granular. You're getting weekly readouts, but also you're actually seeing that precipitous drop that we saw in relation to 2-week wait and then the start of a recovery. So this is why you need real-time data. And one of the things we're doing now is setting up across the United Kingdom, so England and the devolved nations, I'm based in Belfast in Northern Ireland, a real-time data network that will not only help us in relation to COVID, but will also help us to much more accurately look at the position in relation to cancer across the United Kingdom. Next slide, please. The other thing we did was we looked across the whole cancer services, across the pathway. And you can see here, just very briefly, we see presentational delay, so screening essentially stopped, referrals dropped significantly, diagnosis dropped significantly, ways in which we could do diagnosis, for example, endoscopy, which we use for a number of cancers, including bowel cancer, dropped over 76–80%. So again, real challenges in relation to our cancer services and real challenges for either individuals who have a suspicion of cancer or patients who are being treated for cancer. And the other area is cancer research. So 30% of clinical trials disrupted overall. In some regions, that was as high as 80%. Discovery research, translational research was also shut down. And those of you who have followed the story will know that Cancer Research UK have had significant challenges, funding challenges mainly, in relation to cancer research and supporting cancer research across the UK. Next slide, please. And so this really worried us. And the other thing we said was, well, can we look at this in relation to what's the potential excess mortality? So what I've shown you so far is all based on data in the here and now. This is looking at modeling data, looking at excess mortality in patients with cancer, but also using that real-time data that I showed you to inform our model. But this is a model, so just putting that caveat in front of you to make sure that you're aware of that. But even still, between 7 and nearly 18,000 potential excess deaths in people with cancer due to the effects of the pandemic. Next slide, please. So again, very worrying. And one of the things that really, sort of makes me wake up at night in a sweat is the fact that we've done so well in relation to cancer research across the United Kingdom and its impact in relation to cancer care. So what we've seen is 5-year anticipated survival across the United Kingdom has gone up over the last decade. However, what we're starting to see is some of the data that we've shown here and that other people have contributed to this effort. This has been very much a pan-UK effort. What we're seeing is that for certain cancers, particularly colorectal cancer, we could be set back nearly a decade in terms of our 5-year anticipated survival rates. Next slide, please. So what do you do with this data? Well, one of the things we did was present it to the European Cancer Organization. We felt this was not specifically a UK problem, and a lot of interest, similar scenarios, drops may be less profound, and that's led to us setting up a European Cancer Organization special network on COVID-19 and cancer, which myself and Miriam Kluwer are delighted to co-chair, and we're going to come out with a report in relation to the state of play in Europe at the European Cancer Organization Cancer Summit in November. We also provided the evidence base into WHO Europe's 70th Regional Committee meeting in Geneva, which we attended virtually. And again, you can see that data as well if you're interested in it. Next slide, please. So what is the impact of this? One of the things that's been really important is our way of sharing it with stakeholders, with the NHS, with the 4 chief medical officers, with the cancer director, National Cancer Director for England, feeding into SAGE, which we feel contributed to the decision to start restoring cancer services. You can see there obviously a lot of media attention, which is important, because one of the messages that we want to get across is, if you are somebody who, for example, feels they have suspicious symptoms that may be cancer, we really want to encourage you to attend your GP and then be referred on to your GP if that is necessary in relation to confirming or refuting a cancer diagnosis. So that's a really important message to get across to citizens and to patients. And the other thing is that very much cancer has become one of the first priorities of recovery because of the effect and the impact of COVID-19 has had in relation to cancer. Next slide, please. What I just want to emphasize is that it's important that this data is out there, and that people are able to see that data. It's important that governments provide this type of data so people can actually look at it. But it's also important that, as well as following the science, as we've been advised that that's what we're doing in the UK in relation to the response to COVID, you also need to follow the data. The other thing I would emphasize is getting back to pre-COVID-19 levels itself is not enough in relation to either diagnosis or treatment. That new normal can't be the same as the old normal. We may have to be actually acting at 130% of capacity to really make a difference in terms of reversing some of the scenarios that I've suggested may happen if we don't act quickly. Next slide, please. The other thing is you can use data not only to highlight the issue, but also to be part of the solution. And this is really important. And this is work that was led by Claire Turnbull, and we were fortunate enough to be involved in it as well, looking particularly in colorectal cancer. And what we found here is that looking at ways in which we can reduce that risk of significant excess deaths and loss of life years by using fecal immunochemical testing. So normally a test we use in screening. Here what we've looked at is how can you actually use it in the context of symptomatic patients and use it actually to triage who really needs colonoscopy in a scenario where you don't have full capacity of colonoscopy. And so that's helped us to prioritize the use of tests, for example, colonoscopy, but also try and reduce that presentational and diagnostic delay that I mentioned earlier in relation to the data that we've used. It is only a short-term solution, so we really need to get back to 100%, or as I say, probably 130% colonoscopy, but it is a way of showing you how the data can be used to actually help in the recovery, as well as highlighting what the issue is. So just to end, one of the things I really want to emphasize, next slide is, please, given that data saves lives is what we're talking about here, the power of data to improve cancer care is really effective. And one of the things we're trying to emphasize both to the government, but also to the NHS is, don't let cancer become the forgotten sea in the fight against COVID-19. Thank you very much for your attention.